So first of all, I'm Carlos Rodriguez Diaz. I'm affiliated to the George Washington University Milken School of Public Health. I just recently moved to Washington, D.C. Before that, I was with the University of Puerto Rico School of Public Health. I am still doing research from Puerto Rico in the Caribbean region, and I am very honored to be here, continue sharing with my colleagues in the Caribbean the work that we are doing and the work that we need to continue doing and developed in our region. I'm humbly honored to be here, not only because personally it is an honor, but also because I really appreciate the inclusion of Puerto Rico in Caribbean-wide discussions. Often we are not even considered in Caribbean-wide discussions, and I don't think I have to tell you that. For the most part, Puerto Rico is not even included in Caribbean-wide data. If you look at the reports from UNAIDS and international and global agencies, Puerto Ricans are not included in Caribbean reports, mostly because of our political relationship with the United States. So I'm going to start my presentation by providing a little bit of context on why I'm such a strong advocate of including Puerto Rican experience within the Caribbean context. First of all, Puerto Rico is indeed part of the United States. We are a colony of the United States. That's a politically incorrect term, but it's accurate. Post-colonial and colonial experiences is something that in the Caribbean we know very well. And I think we need to acknowledge that political experience as we understand the HIV epidemic in the region. As part of the United States, we do not have any kind of independence, not even to choose the prioritization of HIV services in our country, despite the fact that our epidemic and our needs are unique, are not as reported in US-based reports. So any federal decision that is made in the US is imposed in Puerto Rico. We don't necessarily partake in the discussions of how we prioritize HIV services in Puerto Rico. And I think that's very important because that explains a lot of the inequities. That's the ultimate social determinant of health in our country. And also I think we need to mention something that is common for most of us here in the Caribbean, and is that we are in a hurricane corridor. So the experience of hurricanes and natural disaster is not foreign to any of us. And we just recently experienced in Puerto Rico the impact of 2 hurricanes, the last one and having the largest impact in Hurricane Maria. And within the political context of Puerto Rico, and having the impact of a natural disaster, we had the perfect storm. We have a natural disaster in a human-made economic disaster, because the depth of Puerto Rico, the colonial experience of Puerto Rico is beyond the scope of what we can control. Therefore, to understand health inequities and how we approach HIV in our region, we need to understand that context. However, if I look at data from Puerto Rico, and in fact, even if I look to data from IIS and official organizations that are represented here, Puerto Rico is not included, not in the Caribbean, not in the US. So I have to look at data that is locally generated and in the context of the US, which is the only place where we can make certain reference. So this is also a call for my colleagues in the Caribbean who are interested in including Puerto Rico. At least you know one person, and that's me, who's interested in working with you. Okay? Thank you. So in the context of the US, Puerto Rico represents only 3 million of, that's the 25th largest territory or state of the United States. However, just San Juan, Puerto Rico is one of the 5 cities with the largest epidemic in the US. And we have really bad numbers when we compare Puerto Rico with the rest of the US. We have one of the highest incident rates, one of the highest prevalence rates, and we are 10th among all the AIDS cases. So looking at data specifically to Puerto Rico, and from now on I'm only referencing work that is also done in Puerto Rico by Puerto Ricans. Our surveillance system have identified until December 2017 over 48,000 cases. Most of them, those cases are now reported as deaths. We have around 19,000 people in Puerto Rico living with HIV, and very few, but still a significant number of children diagnosed with HIV. I have to recognize, for example, that in Puerto Rico was one of the first territories that we eliminated mother-to-child transmission, but that has never been recognized because we're not part of the Caribbean, we're not part of the US, but Dr. Carmen Zorrilla, who many of you know, was a pioneer in doing that work in Puerto Rico. This graph has a lot of information, but basically illustrate that we are very similar to many other places in the Caribbean. We had a change in the epidemic after medication was available in the late 90s. Right now we have a steady epidemic. We're not seeing an increase in deaths nor an increase in incidence. I will be careful making an interpretation of what happened between 2016 and 2017 because we have 4 months of not reporting good data after the hurricane. So yes, we have a lower number in 2017, but I will be careful with that number. In terms of incidence, this is incidence per risk group, and Puerto Rico in the last decade have experienced, well, almost 2 decades now, have experienced a shift in the epidemic. Many of you might recall that Puerto Rico had most of the HIV cases reported among injecting drug users, and that was quite unique in the Caribbean. It was only compared to Bermuda, and now we're seeing that it's a sexually transmitted infection mostly affecting men who have sex with men and transgender women. It's not included here, but the estimate is that from 10 to 17% of the trans people in Puerto Rico are being diagnosed with HIV. And I think it's relevant as I've heard a couple of questions regarding trans populations. And the most affected group in terms of age are unfortunately the youngest, between 20 and 40 years old, also MSM. So basically the incidence is among young MSM. This is also happening in the context of what I've been calling an epidemic of syphilis. This epidemic of syphilis started in 2012. We are still reporting too many cases of syphilis, particularly among men and specifically among who have sex with men. This is not caused by PrEP because these numbers were there before PrEP was available. PrEP became available in Puerto Rico in 2012 after the Federal Drug Administration of the US made it approved the treatment. However, it hasn't been widely implemented. And here I'm sharing some of my own research data regarding PrEP. We just finished collecting data. This is a sample of 191 men who have sex with men, not including transgender people. Good news, many have heard of PrEP, 85%. Many of those, 64%, are willing to take PrEP. A third said that they need more information about PrEP, which I think is a good indicator. However, more than a third reported that they would not take PrEP because they cannot afford it. And in the context of Puerto Rico, PrEP is very expensive because we only use branded treatment, Truvada basically, okay? We are also exploring how do we implement PrEP in the continuum of HIV care, but also in primary care, because this is a new approach on how we prevent HIV. We don't need to only work with HIV clinic, we need to work with primary healthcare centers where we are doing already primary care and prevention. However, many barriers that have been mentioned already and that are common in the region, like stigma, discrimination, and the lack of competencies of healthcare providers are pushing back in the implementation of emerging HIV prevention strategies. In a study that we conducted with LGB, lesbian, gay, bisexual individuals, what we have reported is that they are not disclosing sexual practices or sexual orientations to the healthcare providers, and further, primary healthcare providers don't feel competent in providing care to LGBT individuals who we know are at an increased risk for HIV infection. So to me, this is screaming, we need to do intervention with healthcare providers to build competency. Okay? We need to go beyond the interventions to increase acceptability among the individuals, but to work with structural interventions. This is a cascade of care in Puerto Rico. Yes, it's very promising, looks very nice. We have almost 80% of those who are in antiretroviral therapy are achieving viral suppression. However, almost half of all the people who are HIV positive are not achieving viral suppression. And finally, we conducted a study on comorbidities among people in Puerto Rico. TB is not as common in Puerto Rico, so what we are really managing are chronic conditions like dyslipidemia, alcohol abuse, hypertension, who are common among people with HIV in Puerto Rico that are getting old. And that's the result of good access to care. They're getting treatment, but they're also getting old, which is a natural process. So we are managing what comes with the medication and what comes with aging. And finally, right now we are doing a lot of work on what happened after the Hurricane Maria. First, one thing is the response. So I agree with Lori, just the kind of precedent that we have in the US is having an impact on healthcare response locally and internationally. So we need to study that. We have less resources. And further, we need to understand what was done in Puerto Rico to retain and provide continuity of care for people with HIV after having such a bad impact of a natural disaster. So we just got funded by the National Institutes of Health, and we're going to do some longitudinal analysis. We are also conducting some secondary data analysis because we were conducting research when the hurricane happened. So we have kind of a natural experience by having a pre and post research data. And what we have noticed is that nearly 3,000 people were documented as death after the hurricane. And just using data from the death registry, we have identified at least 89 people that also had HIV as one of the causes for death. So we don't know what happened, right? So that's part of the research that we're going to do. And also people have documented that they lost access to their clinics, how they share medication with people they knew, so they can go through the aftermath of the hurricane. So that's my presentation. Thank you.